Measuring blood pressure and pulse rate. A short review. Blood vessels, arteries, veins, capillaries. All arteries carry blood away from the heart. All veins carry blood to the heart. Most arteries carry oxygenated blood. Most veins carry deoxygenated blood. The pulmonary veins carry oxygenated blood to the heart. The pulmonary artery carries deoxygenated blood away from the heart. Veins have valves that prevent blood from flowing in the wrong direction. Veins are wider than arteries. Contraction of body muscles helps the blood flow through the veins. Arteries have more elastic tissue and a thick muscular layer to cope with the high pressure of blood flow caused by the heartbeat. Capillaries transport blood from the arterioles to venules. They are microscopic vessels which are in most of our organs. They are one cell thick, so they allow exchange of gas, O2, CO2, salts and water to occur between the capillaries and surrounding tissue. The pulse may be palpated at any place that allows an artery to be compressed against a bone. Pressure waves generated by the heart and systole moves against the arterial wall. The pulse can be used as a tactile guide to determine the systolic blood pressure, diastolic not palpable. The pulse pattern can be clinically significant, so it is important to note the rate in beats per minute, the rhythm of pulse, fast, slow, irregular, the strength of the pulse, absent, barely palpable, easily palpable, full, bounding. Your pulse varies depending on your age, level of fitness and how active you are being. A resting pulse is used in practice to record rate. The pulse rate needs to be taken over 1 full minute. The normal heartbeat. YouTube animation. http://youtube.b/rise4the FWMA8. AFL is a heart rhythm disorder where the heart beats fast, but in a regular pattern. AFL makes a very distinct sawtooth pattern on an electrocardiogram, ECG, a test used to diagnose abnormal heart rhythms. An irregular heartbeat, arrhythmia, that can lead to blood clots, stroke, heart failure and other heart-related complications. Quivering heart. Terminology: slow pulse rate less than 60 bpm equals bradycardia. All are taken at rest. Slow pulse rate less than 60 bpm equals bradycardia. Fast pulse rate greater than 100 bpm equals tachycardia. Irregular pulse, related to palpitations, or feelings of having rapid, fluttering or a pounding heart. All these need to be referred to a healthcare professional as they indicate an underlying problem. Ask the patient if they are aware of any problems. When you document the rate, also document the rhythm, for example, regular or irregular. What else can affect the heart rate? Caffeine and alcohol increases the strength and frequency of the heartbeat, therefore increasing the rate. Alcohol is a depressant because it slows the nervous system, not the heart. Exercise increases the heart rate, but someone who exercises regularly may have a low resting rate. Disease affects the heart rate. Thyroid disease can either make the rate faster or slower depending on the type of disease. Drugs, medical and recreational, for example digoxin and beta blockers, decrease HR. Recreational drugs tend to increase HR. Count the heartbeats for 60 seconds, or for 30 seconds and multiply by 2. It needs to be a resting pulse rate. Remember to check rate, rhythm and strength. Temporal, external maxillary, facial, carotid, brachial, radial, femoral, popliteal, posterior tibial, dorsal pedis. Blood pressure. What is blood pressure? Blood pressure refers to the force exerted by circulating blood on the walls of blood vessels. The pressure of the circulating blood decreases as blood moves through arteries, arterioles, capillaries, venules, and veins. Blood pressure values are reported in millimeters of mercury, mmHg. Blood pressure is recorded as systolic over diastolic, for example 120/80. What is blood pressure? Tap and hose. The systolic arterial pressure is defined as the highest pressure in the arteries, which occurs from the contraction of the heart. The diastolic arterial pressure is the lowest pressure, which occurs from the heart being relaxed. Measures of arterial pressure are not constant, but undergo natural variations from one heartbeat to another as well as throughout the day. Blood pressure also changes in response to stress, nutritional factors, drugs, or disease. Systole is the contraction of heart chambers, ventricles, driving blood out of the chambers. The chamber valves are closed. Diastole is the period of time when the heart fills with blood, relaxation, after systole, contraction. The chamber valves are open. The heart is at rest. High blood pressure, or hypertension, is defined in an adult as a blood pressure greater than or equal to 140 mmHg systolic pressure or greater than or equal to 90 mmHg diastolic pressure. High blood pressure directly increases the risk of coronary heart disease, which leads to heart attack and stroke, especially when it's present with other risk factors. High blood pressure is the most important preventable cause of premature ill health. Around 5.7 million people have undiagnosed hypertension. There is no universally accepted definition of hypotension, low blood pressure. However, NIH considers 90/60ths of a millimeter of mercury hypotension. Risk factors for developing hypertension: obesity, physical inactivity, high consumption of alcohol, high intake of dietary sodium, low intake of dietary potassium, stress, increasing age, cigarette smoking, increased blood cholesterol. Patients with systemic diseases including diabetes mellitus, renal disease, peripheral vascular disease, family history of hypertension, CHD or stroke. Measuring blood pressure. NICE Clinical Guideline 127, Quick Reference Guide, August 2011. Healthcare professionals need adequate training and should have their performance reviewed periodically. Devices for measuring BP must be properly validated, maintained and regularly recalibrated according to manufacturer's instruction. Ensure an appropriate cuff size for the patient's arm is used. Standardize the environment, relaxed temperate setting with the person quiet and seated with arm outstretched and supported. Palpate the radial or brachial pulse before measuring BP, blood pressure measurement. With electronic blood pressure monitors. Points to note. If checking an electronic device against a mercury or aneroid sphygmomanometer, the blood pressure may differ slightly between devices. It is good practice to occasionally check the monitor against an aneroid sphygmomanometer or another validated device. It is important to have a monitor calibrated according to manufacturer's instruction. These devices should not be used for people with an irregular heartbeat, atrial fibrillation, or heart rate lower than 50 beats per minute. Blood pressure measurement. Estimation of blood pressure by auscultation, listening, NICE Clinical Guideline 34 partial update of CG18. Standardize the environment as much as possible, relaxed temperate setting. Patient seated - arm outstretched and supported. Correctly wrap a cuff containing an appropriately sized bladder around the upper arm, see diagram, and connect to a sphygmomanometer. Palpate the brachial pulse in the antecubital fossa of that arm. Rapidly inflate the cuff to 20 mm of mercury above the point where the brachial pulse disappears. tilde 150 to 160 mHg. Connect a stethoscope and place the diaphragm on the brachial artery, inside elbow, and listen for the pulse. Deflate the cuff and note the pressure at which the pulse reappears, the approximate systolic pressure. Continue deflating to the point at which the brachial pulse disappears, the approximate diastolic pressure. Phase I, clear tapping sound, SBP. Using one hand, place the stethoscope over the brachial artery, ensuring complete skin contact with no clothing in between. Slowly deflate the cuff at 2 to 3 mm of mercury per second, listening for Korotkov sounds, pulse sounds. Phase I, clear tapping sound, SBP. Phase II, auscultatory gap, swishing sound or soft murmur. Phase III, loud slapping sound. Phase IV, sudden muffling of sound. Phase V, disappearance of sound, DBP. The first appearance of faint repetitive clear tapping sounds, gradually increasing in intensity and lasting for at least 2 consecutive beats. Note the systolic pressure. A brief period may follow when the sounds soften or swish. In some patients, the sounds may disappear altogether. The return of sharper sounds becoming crisper for a short time. The distinct, abrupt muffling of sounds, becoming soft and blowy in quality. The point at which all sounds disappear completely. Note the diastolic pressure. When the sounds have disappeared, quickly deflate the cuff completely if repeating the measurement. When possible, take readings at the beginning and end of consultations. Nikolai Korotkov, 1905, Russian Sujin. 30. Important terminology. High blood pressure equals hypertension. Low blood pressure equals hypotension. Fast pulse rate equals tachycardia. Slow pulse rate equals bradycardia. Aneroid mercury conclusions. Pediatrics. 2012 May, 129-5, E1205 E1210. EPUB 2012 April 16. Comparison of mercury and aneroid blood pressure measurements in youth. Shaz, Dolan L.M., D'Agostino Erbe Jr., Standiford D., Davis C., Testaverde L., P. Hoker C., Daniels S.R., Urbina M., for the Search for Diabetes in Youth Study Group. Source: Division of Endocrinology, ML 7012, Cincinnati Children's Hospital, 3333 Burnett Avenue, Cincinnati, Ohio 45229. ame.shotcchmc.org. Abstract. Objective. Because of concerns about the safety and environmental impact of mercury, aneroid sphygmomanometers have replaced mercury-filled devices for blood pressure, BP, measurements. Despite this change, few studies have compared BP measurements between the two devices. Methods. The Search for Diabetes in Youth study conducted a comparison of aneroid and mercury devices among 193 youth with diabetes, 48% boys, aged 12.9 plus or minus 3.7 years, 89% type 1. Statistical analyses included estimating Pearson correlation coefficients, Bland-Altman plots, paired t-tests, and fitting regression models, both overall and stratified by age, less than 10 versus greater than or equal to 10-18 years. Results. Mean mercury and aneroid systolic and diastolic BPs were highly correlated. For the entire group, there was no significant difference in mean systolic BP using the aneroid device, but there was a minus 1.53 plus or minus 5.06 mm Hg difference in mean diastolic BP. When stratified by age, a lower diastolic BP, minus 1.78 plus or minus 5.2 mm Hg, was seen in those greater than or equal to 10 to 18 years using the aneroid device. No differences in systolic BP were observed, and there were no differences in BP by device in individuals less than 10 years. regression analyses did not identify any explanatory variables. Conclusions. Although a small discrepancy between diastolic BP measurements from aneroid versus mercury devices exists, this variation is unlikely to be clinically significant, suggesting that either device could be used in research or clinical settings. Aneroid. Mercury.